Good morning, everyone. Happy 10th, and congratulations. This is amazing to be here, and it's not lost on me that I'm here on the 10th anniversary, and 10 years is when we start talking about the adolescents starting out. So it's an honor to be here. So I know we were talking about the sweet storm, but really my take home is that autonomy is not automatic, and I would like for us to be able to remember that. We'll have a look at statistics a little bit, and then look at a conceptual framework for adolescent health and the chronic care model, as well as a threads framework. How do we actually put all the information that we get from these young women and men in terms of their care? So from a global perspective, we find that the type 1 diabetes in children and adolescents 0 to 19 is at 149,500. And these are the new cases. And this is in the context of a global population of about 2.6 billion. And when we look more closely even at the number of prevalent cases, they're at just about above 500,000 for 0 to 14 years. What really stresses me a lot of the times with these numbers is that adolescents are lumped with the preteens and the under fives, and so we don't have a very clear picture all the time of what's exactly happening with the adolescent. So this study that had been done that looked at the diabetes prevalence from 1990 all the way till 2021, and just for orientation, the 10 to 14s are cream colored, the 15 to 19 are in green, and the 20 to 24s are in gray. And on your left, you note during the course of this one is very ahead of me, so I hope I'm pointing correctly, yeah. So what you notice is that especially for the 15 to 19 and the 20 to 24-year-olds, there is that in terms of prevalence per 10,000 that is gradually going up, and highest for the 20 to 24s. And over to your right, you also notice in terms of regions, and just for orientation, the prevalence is per 100,000. And here we have Eastern and Central Europe, and also Central Asia. Then we have the high-income countries right there. And on the far end is Sub-Saharan Africa. I'd like to posit it that in terms of prevalence, I think our numbers are higher than this, but when we look at how probably we screen and how we diagnose, it may not be as robust as in the high-income countries, but again, we still see quite a high number in the 15 to 19 and 20 to 24-year-olds. So the reason why I'm bringing this up is to say that we have a grand opportunity to be able to impact how we understand the young person in terms of their development, and then also in terms of, thank you. Thank you so much. We have an opportunity to be able to leverage on what their development looks like, and also help them go from one step to the next with much more ease. So again, with type 2 diabetes, and we see the same thing happening from 1990 all the way through to 2021. You notice, again, the highest number is in that 20 to 24, and the 15 to 19s are actually coming up quite a bit. So when we think about, from the perspective of the social determinants of health, what are the conditions in which these young people are born? How do they grow? How they work, they live? And what are the forces and systems that are shaping and conditioning their lives? And how do we arrange it in a framework that makes sense to us and helps us sort of goalpost what are the different things that we need to do in the clinical setting? When we think about it from the perspective of the conceptual framework and looking at the life course approach, thinking through the fact that whatever happened during conception has a ripple effect in terms of early childhood development, and then when we do go into the adolescent stage, we find that things like puberty and in the case of diabetes, puberty does have its impact in terms of how it does present and how it does morph. But in addition to that, we think about what their social determinants of health look like in that context, as well as what their risk versus protective factors are in the context of this young person and where they live and work. Then we also look at what their health-related behaviors look like and what their state is and how we can be able to motivate them to improve on them as well as their outcomes, because we have seen in growing abundance that this has a ripple effect into their adulthood and into their survival. And so when we think about the chronic care model for the young woman, you want to actually work towards the self-management support model and want to be able to have systems around them that promote that more and more. You do want to have a more patient-centered approach and understanding that not one size fits all, as well as preparing the team that's going to take care of this young person and having this balance between an informed and empowered young person and family, and also a proactive and prepared team as well, so as to be able to improve the outcomes. So I come back to this, that autonomy is not automatic. I think in the pediatric field, a lot is taken for granted because we expect babies to be sitting by 6 months, standing by a year, and being able to start walking and talking. But what happens when we think about it in the context of adolescent growth and development that has been interfered with by a chronic illness, and more specifically, one like diabetes that comes with a lot of lifetime implications. And so when we think of the areas of self-management support, we think about the adolescent development. And we talk about it from the perspective of the physical. So thinking about the brain and how the brain from age 10 to 25 is in growth and development, and starting, and I always tell people, from the back coming to the front. So the part of the brain that's more responsible in terms of learning, in terms of emotions, in terms of risk-taking, sort of taking a lead role for some time, and the frontal cortex, where the executive suite being is not as developed as fast as the more posterior aspects of the brain. Looking at it also from the perspective of the psychosocial development of this young person in terms of what is expected in terms of society, how are they growing in a particular setting, and then their cognitive development and understanding they're going from a very fixed, more rigid sort of development stage where they follow instructions to the letter, going into early adolescence where now they're starting to sort of question authority. It's not as rigid. We're trying to think about how do we get them to think more logically without making it look so rule-based, because they're likely to resist that, bearing in mind that there is also a lot of peer influence and pulling away from the family. And also just balancing that with the fact that there is diabetes sort of looming. And so looking at this adolescent development, understanding that the physical, cognitive, psychosocial doesn't all happen at the same time and can be staggered and happen all at different points in time. So the key things being able to understand what is their level of understanding and what is their capacity to be able to understand what's going on with them, and the capacity to be able to make certain decisions, and the availability of resources to be able to support it. And all this working towards transition to adult care. So for a lot of people in the adolescent world, we talk about the HEADS assessment. And in North America, they thought about expanding this from the HEADS, what is already known, to the THREADS assessment, to be able to give us a framework by which we can latch onto in terms of just trying to be able to put all these pieces together and come up with various goalposts that we can be able to support the young person with. And so, very quickly, T standing for transition, and then H, home, and then the RX, which we all know, and I think we prefer to write the full treatment, and then education, eating, activity, drugs, sexual reproductive health, and then looking at safety, suicidality, mood, and then finally screens. So when we think about transitions, you do want to ask the young person what their understanding of diabetes is in their words, and trying not to paraphrase that. You want to be able to understand what they understand to be the implications of this diagnosis on their body and their future, if they have a concept of that. That helps you get a sense of where they are cognitively without having to do too many tests. The other thing you want to find out that's really, really important is in terms of home, being able to understand what the home dynamic is, and especially in the context of who takes care of you, who pays for the medication, what has the impact of diabetes been on the home? And there are different ways that you can frame this question. And the importance of being able to understand what's happening in the home setting is that the parent or caregiver has taken a really big role in terms of care. And when you're thinking about transition, you do not want to invalidate their actions, and you want to be able to sort of walk with them, having understood what their context is in the context of the family. From the treatment perspective, you do want to understand in terms of the medication that they're taking, insulin, what type, what time, what dictates how much they're taking, what are the various things that they're doing. Are they doing what I'm hearing nowadays called raw bolusing or that sort of thing? And you want to understand why they do what they do. But in addition to that, you also do want to understand how it makes them feel. Because a lot of them, in terms of the treatment with injections, with certain medications, it does change how their bodies do appear. And you want to be able to sort of address those concerns that do come up as a result of how they feel around their treatment. When it comes to education, it is not just in the Kenyan sense of were you number one, were you number two, but you really want to understand what it is, what their learning experience has been, and the impact of diabetes on their learning experience. You do want to be able to also understand what their future goals are, and sort of using these goals as what I call the hook, the thing that sort of keeps them motivated and going and moving forward. When we think about eating, more and more we're starting to see that for a lot of young women and young men, we're starting to see the upsurge of eating disorders that do come up. With diabetes, I know there's a lot of carb counting, there's a lot of consideration with nutrition, and you do want to understand what their state of mind is in terms of how they view themselves, how they view their body, and the relationship that they have with food, and being able to challenge that, especially in the context of when it's starting to take the wrong direction. I think we do need to proactively screen for eating disorders more so with these adolescents and young people. In terms of activity, in the clinic setting, I always like to know what their connections are. Again, adolescents are very peer-centric, so you do want them involved in clubs, you do want them involved in teams. And I'll give an example just very briefly of a young man who was having poor control of his sugars, and it kept landing in the hospital, and so eventually the endocrinologist sent to my clinic. And one of the things that I found out is that he always knew his sugars are off, even without checking his sugars, and it's because he really loves football and couldn't dribble the ball well when his sugars were very high. So he would always tell me, Daktari, I know when my sugars are off, I'm not able to make my goal. And so part of finding out about activities and his love for sport has been part of the motivator that we are using for this young man to be able to get him to stay on his medications. Equally, I have, there's an 11-year-old who really loves to bake, and so we're putting together the eating and activity part, because initially the nutritionist had just told her about what she shouldn't eat, forgetting to ask what she actually loves to do, which is baking. And so in protest, started baking cakes and would give a sliver of a piece to the family members and leave 3/4 of the cake for herself. She understood that diabetes is for the family, and the cake is for me. Since no one is asking me, I'll go ahead and still bake my cakes. So bringing to the point that we do need to find out where they're at and sort of work with them to help them achieve their milestones in terms of diabetes. When we talk about drugs, And I know here I might get beaten off the stage a bit, but I look at it from a harm reduction perspective because I want to find out, what are you curious about? What have you experimented with? And so I'm having more and more young people coming and saying, Dr. Jerry, yes, I know I'm supposed to take my insulin, but I have a party on Saturday and everybody is going to be drinking. What do I do? And so we have a conversation about alcohol and the different percentages of alcohol and the impact that alcohol has on the adolescent body. Rather than saying, no, don't take alcohol, you will die. So you have to start thinking about reframing some of these conversations so as to be able to get more information through. When we think about sexual reproductive health, you do want to understand what their goals are for their body and the changes that are happening with their body. And then utilizing what their goals are, what the changes are happening, and utilizing this to be able to set up a model that you can keep coming back and occasionally checking on. You do want to ask them about a few P's. You want to ask them about their period. You want to ask about their partners. You do want to find out if they've had any past infections, any past pregnancies. You do want to understand that if they have been sexually active, did it happen with their permission? And based on that information, being able to then craft part of your framework for this young person. And then we're seeing a growing amount of research that is connecting an increasing concern for mood and anxiety and suicidality that has been linked with chronic illness, and more specifically with diabetes, particular lung illnesses, and things like cystic fibrosis and sickle cell. And it's important to constantly being able to screen them. And there are some screening tools that we can use, like the PHQ-9, the GAD-7, and the Columbia suicidal rating scale, just to be able to be sure that the person that you are sending home, apart from taking their medication, is safe to be able to go home or back to the school setting. And then finally, screens. And screens is not just television. We're thinking about social media. We're trying to think what is constantly on their feeds, what is on their TikTok. It's interesting to find that if you check on your TikToks now, there's a lot of different content giving all sorts of information. And so for you as the point of authority, you do need to have some legit TikToks that you can refer them to if that is their chosen mode of getting information, as well as talking to them about having sort of like a refresh in terms of their feed, because what we're seeing now in terms of the research is, especially for the younger girls aged 11 to 13, when the more and more they get exposed to certain elements of social media, it leads to a level of life dissatisfaction, body dissatisfaction, a lot of comparison. And so we're finding that it is driving depression and anxiety more. And a bit older for the boys at 14 to 15, but for the girls it's starting pretty early, and we do need to address that. And so when you put all these things together, when you think about all the information you've collected, you've actually been able to populate some of the elements from the social determinants of health. You've been able to sort of get a sense of what some of the risk and protective factors are, as well as what their behavior and thought process around some of their behaviors are, as well as some of the outcomes that are happening, in addition to the fact that they are growing physically, the things that you can be able to see, and their expected social role transitions. It's important to constantly remind the parents that you do need to let autonomy continue. If you interfere with it, you will have a 25, 26-year-old diabetic who is fully reliant on their parent and not independent at all in terms of how they're able to manage themselves. So it's really, really important to be able to start working through this. And I'm always really, really excited to be able to talk about this, and I can do this all day. And I know in the interest of time, I'll hurry it up. So when we think about the core elements of healthcare transition, you don't have to reinvent the wheel. There is GOT Transition, or gottransition.org, and this is a website about transitioning youth to the adult setting, and it has all these documents and policies that are already in place. So you can be able to download these documents and custom make them for your clinical setting. And so when you want to think about transition and care policies, they actually do have an outline that you can use, tracking and monitoring. Although I know tracking and monitoring, this is your bread and butter, but there are some documents that you can be able to use in terms of transition. And then that conversation around transition readiness and being able to start it as early as 10 years and sort of having this ongoing documentation that whoever interacts with this young person knows at what point in terms of their readiness that they are, as well as looking at planning and what transition planning looks like. And finally, when we get to the transfer of care, that it's not just a phone call, that it's actually documentation that supports this young person, that this young person has in their phone, has on their email, and also going to the adult physician and having that transfer completion happening even up to 6 months after they've left the pediatric setting. And for us at Gertrude's, usually we'll see till age 21, and more so, we're trying to follow up these young people for about 6 months after they transition to adult care, ensuring that they're on the right track in terms of their care. So what I do want to say is that autonomy is not automatic. It's also not impossible. And there are tools out there that can help with that. And we need to keep incorporating the conceptual framework approach and continue this transition process. And we incorporate these core elements more and more. I'm extremely passionate about transition care. And I'm so grateful to have been given this opportunity to share this with you. Thank you.